And thank you, everyone. Good afternoon. I'd like to begin by welcoming you all to this webinar. We have parents, carers, clinicians, researchers and advocates joining us. And we're really grateful to you for taking time to join this important discussion, which will provide a vital opportunity for us to share expertise and strengthen understanding of childhood dementia. The webinar is being recorded and we will be sharing it on our YouTube channel following this event. And during the webinar, you can submit your questions to the Q&A facility, and we will look to answer these at the end of the presentation. My name is Tony Matheson, and I'm the Chief Executive of Niemann-Pick UK, an organisation that has a long history of supporting families, sharing knowledge and driving progress for those affected by Niemann-Pick diseases and other rare life-limiting conditions. Childhood dementia is an area that is under-recognised and often misunderstood, despite there being over 100 neurodegenerative conditions, including Niemann-Pick disease type C, that can cause it. As these conditions progress, families face daily challenges in providing complex, round-the-clock care. The impact on family life is significant, and parents often become full-time carers, nurses and advocates all at once. Careers have to be put on hold or even ended. Relationships become strained and siblings often take on caring roles of their own. And the effect on mental and emotional health is equally profound as families live with constant anxiety, uncertainty, anticipatory grief, exhaustion, and ultimately bereavement. The systems that are meant to support them are increasingly fragmented and inconsistent. They experience many challenges in navigating between health, education and social care services that don't always recognise the unique needs of children and families living with childhood dementia. That's why organisations like ours, next slide please, Raresh, are working tirelessly to bring visibility to childhood dementia, to push for better coordinated care, timely diagnosis, equitable access to therapies and greater investment in research. Along with our LSD collaborative colleagues, the MPS Society and the BDFA, NPUK is proud to be working with Alzheimer's Scotland and parent carers, and along with a host of expert health and social care professionals, to launch a white paper on the state of childhood dementia in Scotland. This collaboration aims to build on the excellent work of the Childhood Dementia Initiative in Australia, who are now leading global awareness efforts. Today's webinar will shine a light on childhood dementia, and I'm therefore delighted to introduce our guest speaker, Dr Chris Knifton, a learning disability nurse, dementia specialist and associate professor of neurocognitive and neurodevelopmental care at Montfort University, Leicester. We are very grateful to Dr Knifton, not only for donating his time and expertise today, but also in helping us to raise funds for NPUK. As many of you may be aware, NPUK recently lost its officers and 34 years of organisational history in a devastating fire. This webinar is free to attend, but if you're able, please consider a donation to help us recover and continue our work.
As Tony said, hello, my name is Chris, and part of my interest in this area is not only the work I've done in learning disability, but also the work I've done in dementia over many years. And that's one of the reasons why I feel it's important to raise our awareness about childhood dementia. I want to say at the very beginning, I'm not an expert on childhood dementia. It's an interest I've had since, I guess, 2008, when I started to work as a lecturer, and I was bringing up conditions that we used to work with in learning disability, which now we're associating with childhood dementia too. So I've been campaigning silently in the background. And it's really great I've got this opportunity to share some of those thoughts and insights. We know, for example, that as childhood dementia may develop, then there may be some strategies that potentially we can put in place that may be useful and that we've learnt from the world of dementia, and I want to share some of those with you today. So I guess my first point is our use of the word dementia. And this slide here, it just talks or just talks to you about the different books and contexts we have about dementia, and very rarely does it include a section on childhood dementias. I have to say, there is the odd book that does, and I've read some interesting points in those, but generally it seems to be missing. And as a consequence, when people hear the term childhood dementia, it can become it can cause tension, because dementia for a long time has been associated with older people. And I remember going back in 2008 and teaching some medical students about early onset dementia, and that was working age, and that was met with, that doesn't happen, let alone to talk about dementia when it occurs in children. So it's something that is gradually growing in awareness, and it's really great that societies such as NPUK and the Childhood Dementia Initiative are out there saying we need to hear the voice of people and families who are affected by childhood dementia and recognise the terminology as such. And the questions I've got, it's not really for you to answer, but for you to be aware of, depending on your background. I've not met you, so my apologies. I don't know whether you're a professional or an educationalist or a parent or carer or family member. But certainly for those people who are educationalists or clinicians who go to conferences on dementia, it's really interesting. It's very rare you see a stand or a topic or a discourse about childhood dementias. We were quite lucky, I think, to present this for the first time in Europe not so long ago at the Alzheimer Europe conference, where myself with Gail from the Childhood Dementia Initiative showed some slides about childhood dementia. And then we had a lovely talk from a parent. And then we also had Jill Carson from Alzheimer's Scotland. I'm saying this just to highlight it is out there and it's gradually gathering momentum. And what we want to do is take you along on this journey with us. And if there's anything you can do to help shape our discourse, please do email me. And I'm really happy for Raresh to share my email address if at all needed. And equally, I'm also hoping, particularly if you are working with families affected, there may be some points here that you can take into your practice. So I hope not only in terms of highlighting knowledge and terminology, that there may be some elements that can actually make a real difference today, not just going forward in the future. So this slide, again, I've not put a parent's name, but I do have their permission to share the pictures. This is an example of one young child who developed childhood dementia, and the quotes from parents, from family members, are more important than any educationalist or clinician can say in many ways when we're talking about this as a subject, because it shows people aren't just clinical cases. People are real life people with living and lived experiences, and that should be at the heart of any discourse. So where possible, and I'm a nurse by background, so sometimes I forget, but where possible, I try to not use the word cases. You're not cases, you are people, and we need to listen to your voice and do whatever we can to support and help. But the message here is one quite important, particularly for people who may have not heard of this term before. But the message is, kids get dementia too. Not just older people, not just people of working age and young onset, as we may see on Coronation Street, but also kids can get it too. But sadly, it receives lesser attention. And there could be many reasons for that. Now, as we progress through these slides, do not be worried about too much biology, neurochemistry, etc. That's not my forte, and I don't pretend it is. Where relevant, I'll highlight some terminologies which are medical, clinical, scientific. But my background, certainly as an LD nurse, learning disability nurse, Admiral nurse, dementia nurse specialist, and as a social worker, very much comes from the psychosocial model. So not so much the clinical, that's to the clinical experts. Mine is about the psychological and social impact and what we can do about it. So the scope of childhood dementia and the terminology. So on the first column, I've written childhood dementia. We're using it as a collective descriptor, and the number of conditions that this may fall under will vary as we develop more and more knowledge. And I have to say quite clearly that the the area we're getting this knowledge from is from the wonderful work done in Australia by the Childhood Dementia Initiative. And so far, the discourse suggests there are over 145 conditions that could lead to childhood dementia. That could change over time as we become more aware, but that's the figure we sort of thinking about. So already, it's a lot. If we start to use this collective terminology of childhood dementia, we get some degree of standardization, whether that's national or, as we hope to see, global. If we use this term, we can have a better shared experience, shared learning, and greater shared understanding. That's why terminology can be quite important, so we have this shared discourse or shared language. It increases potential for shared learning, because that way, if you're doing your searches and you come across this term and we're all using it, learning can be transmitted to a broader range of people a lot quicker. And of course, something that the NPUK Society and other societies are really good at is advocating for the rights of families. And if we use shared terminology, advocacy becomes stronger because there's more offers if we use the language together. Now, on the second column, I've just put some of the other terms that I've seen in the literature. So when I've done different reports and writing and guidance, and when I prepare lectures for my students, if I'm talking about childhood dementia, I've got to be very aware that if I use that term currently, it may not address all the literature out there because people use different words. So these are some of the other terms I found in the literature. These terms, for some of you, you may use as your first terminology. For some of you, again, they may be quite rare. But these are some of the words we use. And as you can see, they're quite a lot. They all tend to cover the same sort of thing, again, highlighting the need for this one clear terminology. Now, I remember going back, I think it was several years ago. It was a time when my mom was still alive, and she was getting, it was either Woman's Own or Woman's Weekly, one of those magazines. And I remember flicking it through, as you do, although you don't tell anyone you do, but I was looking through it, and there was this very interesting article, a 4-page spread, and it said, "My child has Alzheimer's disease." And I remember thinking at the time, that's not Alzheimer's disease. And this is way before I met Tony and became aware of the NPUK Society. I remember saying, that's probably Niemann-Pick disease. Let me have a look. And I read through this article, and of course it was. It was a really interesting magazine article that talked about Niemann-Pick. And I thought, this is confusing because it says my child has childhood Alzheimer's. It's a very different condition, but I could see why they use that terminology because it did make people stop and look. So going forward, I think using terms like childhood dementia can really support our collective actions together globally. There are people out there who prefer to use the more scientific terms, but equally, I like the clarity of the words childhood dementia. I'm also I guess, if I put my social work hat on, as opposed to my nursing hat on, aware for challenges of using that term. There may be families, there may be clinicians, there may be educationalists who find that using the term childhood dementia can be quite confusing and can cause problems within family discussions. Families may believe that dementia cannot affect children and therefore become very defensive. So again, we all take our words differently, but if we start talking about it more, we may get this sense of familiarity. And in essence, the concept is this collective term. So, is it really rare, childhood dementia? And I think when we look at individual conditions like Niemann-Pick, Batten, etc., and the 145 plus diseases out there, individually, they can be considered as rare conditions. But if we use this one umbrella term, it becomes less rare and our collective action can start to become a lot more stronger. So this is why one of the, I guess, rationales behind this talk is to spark off our collection action together to recognise childhood dementia as an umbrella term. Okay, I'm just going to pause there just to check in with you, because I tend to talk quite quick. I've got autism, so sometimes I forget myself. But I just want to check in with you as the audience. Is this okay for you? Do you need me to slow down, or are you all right? I can't see the comments box, so if things are okay, give me a thumbs up or a thumbs down, Tony.
Thank you, Chris. Everything is great, and yes, great speed according to the audience. So thank you so much.
Oh, that's perfect. Thank you very much. Always important to check in rather than continuing blindly and people not getting it. So I appreciate that. Thank you. Okay. So if we're going to use this term, childhood dementia, what is it? Who does it refer to? So it's an umbrella term for a range of childhood neurodegenerative disorders. And we've got some common features which an article by Nunn et al. Discussed. This global neurocognitive decline. And when we use the word global, we don't mean international. Here, global refers to multiple areas of the brain. So when we use the word focal, it means one part of the brain. If we use the word global, it means multiple parts of the brain. So we're saying here that there is global neurocognitive decline. And what may happen sometimes in dementia is it may start off in one place, but as the condition develops, more and more parts become affected. That's what we mean by global. We've got multiple developmental skill loss and decline. So as people are learning skills, those skills then start to drop, deteriorate, regress. We may use different terms, but essentially what's learned becomes lost. And that's really important when we consider the term dementia and we see the value of that word in itself. It has been used randomly in the past for many different things, but when we look at what it means, it's Latin, I can't say the word, derivative. De, as in DE, means loss. Mentia means mind. So dementia means you've lost something that you had before. And that really sums up quite a lot of the effects of having dementia. You have learned a range of skills, but then gradually as the condition progresses, those skills you have learned, those developmental milestones in children, become lost. D, loss, mentia, mind. And in the sense of mind, we're talking about brain and mental health, all put together, this global decline. Enduring and progressive loss of previously acquired developmental skills probably sums that up a lot better. But again, the word dementia, that's exactly what dementia is meant to say and talk about. It's just in our society, we have for such a long time associated with older people that there may be people out there who forget to associate. It can happen to children too. Now, there are a range of conditions. Most of them I can't spell or even say out. So I've just listed some there. I'm not going to read them off the screen because sometimes I can't pronounce them, but it's just to highlight that there is not one specific cause, but a range of many. And I'm quite aware that there's going to be people here from Niemann-Pick Society, Niemann-Pick UK, and parents who may have a lot more knowledge about the individual conditions than I have, and I won't pretend I know. What I do know is about the dementia aspect, but what we can safely say is there's a range of different conditions out there caused by many, many different things, but what they have in common is they may all result in the features we've got, this global neurocognitive decline, this developmental skill loss, and this progressive loss of previously acquired skills. And you can see, if we all came together under this umbrella term of childhood dementia, when we're trying to look at things we can do when children and adolescents reach that stage, we have got together a very powerful voice. And knowing the work of Childhood Dementia Initiative in Australia, we have globally a very powerful voice, and we want people to listen. So the good example is in Alzheimer's Scotland. I think they're meeting with the Scottish Parliament sometime in December. And what we want to do is, as our collective voice, is talk to as many people as we can, to hopefully they'll listen. And then we can start looking at not only treatments and ways of preventing, treating the clinical aspects of a condition, but also, if we start using this term, perhaps there's things we can learn that we use in dementia currently that perhaps we can start applying to children too. And I've got some examples of that, which I'm going to discuss with you later on. Now, I've mentioned about adult dementia and childhood dementia and the differences, similarities. And I think what I've got here is to highlight that some of the more common causes. Now, because the literature and research on childhood dementia is quite poor, these are currently approximate estimates. So it may be well in time these change because the research isn't clear out there and people aren't using standardized terminology. So these are estimates, approximates. What we do know is in adult dementia, and I'm also aware that there could be people here as delegates who may have a family member with an adult dementia. What we do know is we have 4 common causes. I think looking at my numbering there, the number's gone a bit wrong. So it should be 1, 2, 3, 4. So there's 4 common ones. Overall, we can say there's over 200 different types of dementia that affect adults. And these are the common ones. Alzheimer's disease. People may also have a diagnosis called mixed type, and that's usually Alzheimer's with a vascular dementia. And the vascular dementias are ones usually caused by stroke or something similar. We then have the Lewy body dementias, which are quite similar, that there's a subtle difference, but on the same continuum as Parkinson's disease caused dementias. And then we've got the frontal temporal lobe dementias. So these are the 4 common ones that we find in the UK, but there are some very rare ones too. Corticobasal degeneration, Kuru, we don't see much of that in the UK at all, but the list can go on in detail. Korsakoff, etc. So in the same way, in childhood dementia, we've got some ones that we may have heard of. There's some very rare conditions too. And sometimes when doing a talk, it's really important to recognise the common ones, but also to recognise the ones that we don't talk about, because everyone's life matters. So whereas we've got those 4 common ones in adults, the rough guesses, the estimates, that as much as I could find, suggests these are the ones that commonly refer to childhood dementia in the discourses. Batten, Sanfilippo, MLD, and Niemann-Pick. So we know we're up there, but there's so many other different forms and types. So that's a little bit of a comparison. If we say there's over 200 adult dementias and over 145 childhood dementias, the list is growing. And this is why, again, that campaign, when we hear something about dementia, don't forget the children, is a little motto I have when I talk to my nursing students. So, symptomology. These are just some examples of childhood dementia, of symptoms, but I want to say very, very clearly, not all these symptoms will be present. These are general symptoms that we see or feature in childhood dementia conditions. But as with any condition, you're unlikely to get every single symptom. I know when my dad passed away, he had a frontal temporal brain injury. He had some of the classic symptoms associated with that condition, but not all. So we have to bear that in mind. So these are just general ones. So what I've done here is I've split it into 2 different domains, because there's always a risk when talking about dementia that people focus on the neurocognitive dimension. It's still important, but it's not the only dimension theme. What we do know, however, under cognitive, because it's often the thing we are more likely to react to, we have this cognitive ability decline, and that includes thinking, reasoning, understanding, etc. We may find that the child or adolescent has got worsening attention or concentration, and that may be picked up at school. Disorientation to time, place, or person. Memory difficulties. What we tend to find is the memory difficulties are more associated, like with most other adult dementias, with short-term memory loss, and some long-term memories are normally held fast and kept. And a good example is in Batten's, where people start to experience visual loss. What we do know is usually the long-term memories before the vision loss are held and kept secure. It's often the newer memories post-vision loss that can be more difficult. Communication difficulties, including word-finding difficulties and echolalia. Echolalia just refers to repeating, and that can be the same word or the same phrase. And going back to my days in adult dementia practice, I used to run a care home, run a day hospital, etc. And I know, particularly when I think back to my care home work, we would have a lot of people, and I do mean a lot, who would repeat the same phrase over and over again. And that can be quite difficult it was difficult for some of the staff, and difficult for relatives, and difficult for people around them. But that's part and parcel of the cognitive decline, and sometimes it's important to recognise that. And we can talk about later, or perhaps in a different session, what's happening in the brain that causes echolalia. Sometimes as well, more rarely, but sometimes you may get something called echopraxia. And echopraxia is when people repeat the same gestures or movements over and over again. In childhood dementia, it's mostly echolalia, but in other dementias we may see, in adults, we may see echolalia and then rarely some echopraxias. Routine and change can be really difficult to manage, and that can cause what's on the other side, potentially some behavioural manifestations. But routine and change difficulties are usually experienced, as well as potentially some obsessions or fixations. And there could be many reasons for that. It's interesting clinically to talk about an obsession and a fixation as something that's problematic. Now, I spoke to you earlier on that I've got autism, and part of my autism, as you'll probably see in the background, I've got lots of dinosaur plant holders. I'm a bit obsessed by dinosaurs. And they're in my office because that gives me a safe space. I can do my teaching. The teaching can go well or not so well, etc. But then I come back to my office and I've got what I'm obsessed or fixated with, and that gives me calm, stability, security. So what I'm suggesting here, that I know in my autism, I experience obsessions and fixations, but it gives me security and I don't want it changed. So I guess what could be likely here is when we are seeing obsessions and fixations, clinically we can talk about it from a neurocognitive, biological perspective, of course, but also take a moment to think about socially and psychologically what's happening if we have an obsession or fixation. Could it be it's a positive? Could it be a way of coping? Could it be someone finding a sense of security and safety in their brain when everything else is going wrong? So I don't always see obsessions and fixations as being a negative. It could be their way of finding security in their brain. I guess the counter argument could be that depends on what they're becoming obsessed or fixated about and the consequences of that. So I do understand that. I'm not being naive. I'm just suggesting our first step is to not always think it's bad. It could be quite good. But also we need to think about what they're becoming obsessed with. I guess one of the dangers could be if someone gets obsessed or fixated on a certain person, and when that certain person isn't there, then it can result in behavioural manifestations. So potentially it may not always be appropriate. When it does happen, perhaps we could start to think, what does that person do? Why has that person potentially at a subconscious level developed this obsession or fixation with them? What is it about them that may be giving a sense of safety or security? And can we try to replicate that in another person, etc.? So there are ways we can look at it. That's a whole session in its own right, how to support obsessions and fixations, the pros and the cons. But it's just to give you an idea now. And then, of course, on the second column, other possible domains, behavioural manifestations. I'm always conscious about how I write that. We had a long discourse in dementia, in the world of dementia, adult dementia, where we used the word challenging behaviour. And we use it also when I was a learning disability nurse, challenging behaviour, and the problems with that terminology and the negatives that it gave. And in fact, one of my first jobs as an LD nurse was on a challenging behaviour unit, the CBU. And now we look back and think, oh, that's terrible words, etc. So what do we say? What words can we use, particularly for people who are clinicians or educators? What is the correct terminology? I wrote behavioural manifestations there, but what I do want to invite you to be aware of is I don't think it's new to me, but it's a new terminology to me that's coming out in the adult dementia world, and it's called BEN, B-E-N, and that stands for Behavioural Expressions of Need. Because what it means is your behaviour is an attempt by the person to communicate something, a need. And our role is to, where possible, understand what that need is and help them address it. So I'm currently moving towards BEN, Behavioural Expressions of Need. And I think that could fit in really nicely with our discourse about childhood dementia. As we progress down that list, we can see words like restlessness, agitation, the emotional impact, and that's an important thing to think about. How much does a child or adolescent understand about their own potential regression, the loss of skills, things that they once felt proud of their achievements, no longer being able to do, etc. And then the consequence of having things done for you. The adolescent who was quite proud of their image and privacy and so on and so forth, now being dressed by parents, etc. So we mustn't underestimate the emotional impact and what research or work or training or support is there to help children understand the emotional impact of having a condition that's causing regression. Sleep problems and disturbances, and there could be some biological reasons for that, which will be a subject of a different session. Social awareness, psychosis, incontinence, seizures, we see quite often crops up, more so in childhood dementia than it does in adult dementia. Sensory problems, muscle weakness, dystonia, ataxia, mobilizing problems. And I guess one of the domains which is, I find less discussed in the literature, but a really powerful one, is the concept of fatigue. If your brain is struggling for whatever reason, and it's managing to do certain tasks, there's a risk that we may underestimate the energy that the child has applied to do those simple tasks, excuse me, resulting in fatigue. So when we're planning our work and our support and our care, whatever role we're doing with the child, have we planned in moments and opportunities of rest? Because it can be quite struggling. And again, I relate to autism because it's in concrete I can give you. I know sometimes I struggle with social situations. For example, I've just been teaching some students, and when I come back, the fatigue is huge. Not because I'm physically tired, but I'm mentally tired because I've been trying to understand the social cues, the social roles, what I can say, what I can't say, etc. So it has a huge physical impact on me. And applying that rationale to childhood dementia, if people are using what they can off their brain for as long as they can, trying to make sense, we need to understand the amount of energy that they may have had to put into that. So I'm going to say rest breaks, but it's so much more important than that. And if there's anyone watching this talk from a school-based perspective and education and teaching and primary school, secondary school, etc., it's how well do we support fatigue in the children, and do we have an allocated space for children? Let's do a task and let's have a rest break, etc. And what does that save space, because it's safety, but as well as relaxing, what does that look like? And how often are those scheduled? And can people indicate that they just need to take away some time away from all the sensory input and the brain challenges, just to build their strength up again? So fatigue is, I think, least discussed, but one potentially we can start actively putting things in place for. So these are just some examples, and remember, not all are going to be present. Some may be, some may not. So with that in mind, do we have any clear differences between childhood dementia and adult dementia? So on the first column, these are adult and child. So these are examples of symptoms which are shared both with childhood dementia and adult dementia. And I think what we've seen already, or what we've discussed so far, links in with this column: the cognitive decline, the memory loss, particularly short-term memory loss, disorientation of time, place, and person, attention and concentration challenges, and I guess we can also link that to fatigue, the emotional impact of how the child is coping with what they're experiencing, confusion, and here I've written down the BEN, behavioural expressions of need. So all those occur in both adult and childhood dementias. Now, when we're looking at more specifically childhood dementia, there may be additional symptomology we need to think about. Seizures, you do get seizures in adult dementia, but not so often, but it's very common in childhood dementia. And we need to look at what those seizures are. Are they myoclonic? Are they tonic-clonic? So what I mean by that is, are they seizures which are focal, affecting, for example, one limb, or are they more broader seizures where people lose consciousness and they have what we tend to see as an epileptic seizure, and gradually then they come round? So perhaps a bit more research into what are these seizures and what types of seizures, etc. Auditory and visual decline, and that can be physiologically this is happening, or it can be as well different parts of the brain are not functioning as well in interpreting and processing. So many different reasons for that, and usually dependent on the cause of a childhood dementia. For example, we know in Batten's, the visual decline is one of those key features. Movement disorders, and often other physiological changes. Certainly in my experience, I've seen greater physiological challenges in childhood dementia than I've seen in adult. And I would also, again, this is anecdotal based on my experience, childhood dementia appears to progress more rapidly than adult dementia. So those are some of the shared similarities and some of the differences. And if we look at that first column, some of the shared, in the world of adult dementia, we have strategies to address those. Some work, some don't work, but they exist. And I wonder how many people have had, when I say teaching sessions, that may be the wrong term, so forgive me, but awareness sessions, literature, guidance on how those things can be applied to children, because they do exist. How well we can apply to children is the need for more research. And there's some examples I'm going to show you later on in these slides, where I think, I don't know if this works in childhood dementia, but I think it's important we give it a serious attempt to look at, because I think it could make a big difference. So what can we learn from the world of adult dementia that potentially we can apply to children and families? And lots of those things in the first column, we have strategies for. How they work with children, that can be an important avenue for research, funds, grants, people wanting to do something different to meet an unmet need. So points to talk about. So this comes onto this slide. It's just a question. I'm more psychosocial. My doctorate was in the sociology of dementia. But I'm a nurse by background, so I know some basic biology that underpins it. I'm just very well aware that most people will have a very detailed understanding of the biology that affects a particular condition. So I'm not going to go into that into detail. What I am going to talk about is a very basic awareness, and is any lessons that can be learnt, particularly for those of us who may have not looked at the brain as to what can be the cause, as it were. So I've highlighted it in yellow, different parts of the brain, and I've put early childhood, ages 2 to 6 years. What this means is, in this early childhood, between 2 and 6, this is what generally the brain is able to do or not do. I thought it was important just to give you an awareness of this, because if in childhood dementia someone is regressing, they may regress to this part of early childhood, which is why we may see features of BEN, behavioural expressions of need, because what they could do is no longer possible, and they've regressed to this point, and this is why they're behaving in this particular way. It's got a biological basis to it. And of all these, I've listed at the top perhaps one that I believe has the biggest impact. So the amygdala, amygdala, however you want to pronounce it. My wife, who's a play therapist, often laughs at me because I pronounce it wrong. However you want to pronounce it. Very active and importantly reactive at this age. And I put here, children feel emotions intensely but have limited control over them, and that's why you have tantrums and big emotional reactions. What controls the amygdala is the frontal lobe, and at this age the frontal lobe is not properly developed. Now, as people reach adolescence, about from the age of 11, different research will tell you different things. The frontal lobe starts to mature, and that's why for people on the call who have adolescents, teenagers off their own or know of them, their behaviour is rather cheeky, and that's because the frontal lobe is starting to sort itself out. It's posing those challenges. It's helping you find your way in the world. It's making you more confident, even though you've got no right to feel confident, etc., etc. Risk-taking behaviours, even sexual disinhibition and sexual activity, etc. That's the frontal lobe trying to adapt itself to what you're going to be like as moving forward, trying to find your place in the world. Now, as a frontal lobe develops, it starts to mature and put things in place. So we learn those social roles. We have some degree of social inhibition. We have some degree of understanding right from wrong and what's appropriate, what's not appropriate. Our personality starts to take shape, etc. So if the frontal lobe, for whatever reason, goes wrong, what we then are left with is the amygdala, because the frontal lobe is no longer putting the amygdala in its place. The amygdala takes over, and that's why we get some of these behaviours. Now, the other lobes of the brain, parietal, temporal, occipital, the frontal lobe is at the front, the parietal lobe is on the top, temporal lobe is at the sides, and interestingly, the amygdala is inside your temporal lobe, and the occipital lobe is at the back. So if we understand what parts of the brain do what, and then we have an idea of what parts of the brain are being affected. And you may know a lot more about that than I do, depending on the particular condition. We can start potentially thinking about, well, what is working? What can we focus on? What can we make the best of? But more importantly, when someone is displaying behavioural expressions of need, we understand there's probably unlikely to be a biological basis to it based on the amygdala. So hopefully that's useful. It's almost a session in its own right, the biology and the A&P and the physiology, etc., of the brain and brain chemistry, which will go way beyond this session. This is just a very short awareness, just so you understand. We are actually working from what we call a biopsychosocial approach. There's a biology to it, there's a psychology to it, there's a sociology to it. So in our working with children, it's understanding that their experience is based on a biopsychosocial experience. Now, this slide, it's people may use the term differential diagnosis, misdiagnosis. So what is not a dementia? And in the first column, I've written in adult dementia, we have to be very clear. And a lot of my clinical practice when I was a nurse was checking in, is a person's behaviour, and that could be behavioural deterioration, could be cognitive decline, could that be down to delirium? And delirium is a term we use for a physical cause that's led to some degree of cognitive decline. And often that's down to an infection. So if you use the word UTI, it means urinary tract infection. That's very common. And people may get a UTI, and that may become interpreted as, particularly in an older person, they've got dementia. And it's not, they've got a urine infection. And if we treat the urine infection, then those symptoms go. It could be someone who's got dementia and have got very worse very quickly. And people may say their dementia's progressed. And well, I could say, well, hang on a minute. It may not have been. It could be down to a non-treated physical condition, like a urine infection. We treat the urine infection, and then that rapid decline is no longer so much of a decline. So we know delirium is a big thing we look out for if we suspect dementia, firstly. And then if we think dementia is progressing quickly, we check, is that unmet physical health need? Depression as well, that can have a very similar effect. And sometimes misdiagnosis, I've put this here, still today, some people will not diagnose adult dementia. They say it's just a natural part of aging. And we're starting to say that is not the case. But sometimes it's just misdiagnosed as that's what it is to be old. And being someone who is nearer to 60 than I am to 50, I can definitely say that is not the case. So those are the common misdiagnoses in adult dementia. In childhood dementia, I would guess some of your rapid progression, I would suggest just check for delirium first. Although we know dementia may progress rapidly, some of the experiences may be down to a chest infection, a urine infection, sepsis, constipation, medication side effects, polypharmacy. And poly, meaning more than one, pharmacy, the drugs they get, being on too many drugs, polypharmacy could lead to delirium consequences. So always check for delirium no matter what. But then what we also see are these terminologies. These are not dementias, but this is where it often gets confused. The first one, learning disability. Now, from my own experience, my brother had learning disability, and sadly he died during COVID. And that sparked my interest in working with people with cognitive impairments. Now, his was down to the whooping cough vaccine. But learning disability is a huge umbrella term which often focuses on mild, moderate, severe, or profound, different causes, like we have in childhood dementia, but it creates this learning disability. But it's generally static, so it doesn't deteriorate. We do know people with Down syndrome are more likely to get Alzheimer's disease as they get older, but generally the learning disability doesn't decline until they start getting Alzheimer's disease later on in life. So learning disability, it is a cognitive impairment, but it's usually quite static in that sense. It's not declining. And certainly when I was a student learning disability nurse, going back a very, very long time, we had conditions there that we were taught were learning disability that we now know or start to think about it, thanks to the work of the Childhood Dementia Initiative, as actually, is this more aligned to childhood dementia than it is to learning disability? And that's where we get quite a few controversies. When were you trained as a clinician? What were you taught? What do you believe? And where do you draw the difference between having a learning disability and having a childhood dementia? And we tend to look at this concept of decline in cognitive abilities, some of the things we discussed earlier on. And if the condition causes that, rather than putting it in an LD box, does it go in a childhood dementia box? And then we can have a big discussion about why should we put it into a box anyway, etc. But the whole idea is learning disability is often confused with childhood dementia. And that's where I can say, as a clinician, I've worked with a lot of people with childhood dementia, even though when I was doing that, which was in the early 1990s, when I was doing that, we didn't use that terminology at all. And that included Sanfilippo, Rett syndrome, Tay-Sachs disease, etc. The term global developmental delay, essentially, at its most broadest, that's learning disability before we say learning disability, because it could be the child is just slower at developing. So they've got a global developmental delay, which means it's quite likely in the future they may catch up. They're just delayed. And then we've got these conditions: autism, ADHD, attention deficit hyperactive disorder, and ADD, attention deficit disorder. They don't need to be hyperactive. So some people may say that's not childhood dementia, or that's not this particular condition, they're autistic, or they've got ADHD, or it's an LD, or it's global developmental delay. So it's just being mindful that some people, and there may be parents in the audience today as delegates, who may have experienced being given a misdiagnosis until core features of a particular condition may have come out, where you then get your specific condition, such as Niemann-Pick C, etc. So just misdiagnosis occurs in both adult and childhood dementias, but we've got some particular areas we need to look into from a childhood perspective. So diagnosis. Again, you're likely to be much more au fait with this. This is just a very basic comparison between the two. In adult dementia, there's these detailed histories, a very clear physical examination to rule out any physical cause, including things like delirium. We do a mental health examination to rule out a mental health condition such as depression. We may go to memory assessment or memory clinics. And it's interesting we use the word memory assessments in clinics, because not all dementias in adults start with memory loss. Frontal temporal lobe degeneration, the fourth most commonest type of dementia in adults, does not have memory loss as its first symptom because of what the frontal lobe does. It has what the frontal lobe controls as its first symptomology. But we still have memory assessment clinics. Brain scans, that may show atrophy, which just means shrinkage. A means absence, trophy means growth. Absence of growth is shrinkage. So atrophy in certain areas of the brain. And we looked at lobes earlier on. Atrophy in the temporal lobe may suggest Alzheimer's disease because we know the part affected, the hippocampus, is also in the temporal lobe. Atrophy of the frontal lobe may suggest frontal temporal lobe dementia. But equally, a brain scan could pick out something like a tumour, which is presenting as a dementia, but actually potentially may be operable. So we need to do a brain scan just in case it is something that's not dementia that we can actually treat. But however, we can't confirm with full 100% accuracy until we do the brain autopsy. What we tend to have is the most likely probable diagnosis after ruling out other things it could be. In childhood dementia, we still have this detailed history, but what's really important is family history because of the multitude of genetic conditions. Physical assessments to rule out anything that it may be something, but it's not. Delirium of physical health causes, etc. And what we tend to find is a diagnosis confirmed through genetic testing. Now, again, for the parents and family members in the audience, I don't want to downplay the challenges in a diagnosis that you would have most certainly experienced, and the importance of societies such as NPUK, Batten, Sanfilippo, etc., who support family members through diagnosis processes. So it's just 3 points. I don't want you to think I'm downplaying it, because I know it's a really difficult process which can go on for years, particularly when people may say to you, oh, it's okay, they've just got autism or something similar, and you've got to go through the battle of misdiagnoses and advocacy and support. But it's just there really to say the difference between adult and childhood dementia diagnosis pathways. Right, I'm going to move on to the next slide, but I'm going to pause just for a moment because this is one about the more common causes of death. So rather than spending too much on this, depending where you're at, particularly if you're a family member and you're on this journey with your child, this may not be something you want to discuss today. So I'm just going to put it up there, not discuss it. You take on board what you wish to take on board, and you can always revisit the slide later on. Or if necessary, it may be something you contact Tony about to say you'd like a specific session at a point when you're ready to discuss. So with your agreement, hopefully, and again, I can't see the comments box, but I'm not going to discuss that slide because we're not all at that place to be ready to discuss it. But come back to it when you are ready, or do contact Tony if you want some specific discussion. So I'll just pause for a moment. We've got just under half an hour left. I just want to check with the group. Does anyone need, because of the last slide, etc., does anyone need a quick comfort break, or to grab a drink, or just have a little quiet reflection, then come back and join me? Are you happy to continue? It's now 2 o'clock. We've got just under half an hour left. Would you need a 5-minute break? Because we have to discuss some very important things. Pop your thoughts in the comments box, and then Rarez will tell me what you decide to do as a collective.
Yeah, I'm not sure how the best way to do this. Maybe.
Has anyone said anything in the comments box? Do people want to continue, or do people need a break?
We're all good to carry on.
Thank you. Good to carry on, yeah.
Right. Perfect, lovely.
Yeah.
It's always important just to check in, particularly when we discuss some emotive aspects. But if you're good to carry on, so will I. Thank you.
No, that's thanks for that, Chris. Thank you.
Lovely. So, understanding then what helps. What can, now we've got that context behind us, what can help people with childhood dementia? And we know there's some general discussions here that we find in the literature. Music and singing seems to be one of the most highly talked about beneficial interventions. And again, there's some biology and psychology as to why that works well. But music and singing, never underestimated its power. And one of the things to think about is how our brain connects to sound and music. And if I played a particular song, for example, now, well, if I heard a particular song that occurred during an influential period in my development, it would take me straight back to that moment. So sound, singing can have a huge effect on memory, as it can also have on physical movements, different types of memories, etc. Having a designated safe space and place. Now, whether you have that in your own homes, if you're a family member, that could be an important point to have. But also, if you're an educationalist in a school or other clinical setting, do you have a safe space and place for people to go? We talked earlier about the impact of fatigue, but it's more than just fatigue as well here when we're talking about a safe space. It's about feeling overwhelmed and there is too much and I need to go back and find my safe space. We mentioned earlier that could be the cause of obsessions, rituals, fixations, etc., to find a safe space in your brain. So what if we had a physical safe space? And what does that safe space look like? We can talk about the use of colours, the use of fabrics, the use of lighting. What makes a safe space a safe space? Again, a different session in its own right, but enough to start people thinking about it. My safe space, you can see books and dinosaurs and houseplants, etc. Grounding. There's lots of work about grounding, particularly being barefoot on grass. And that's a really interesting concept, particularly as people progress and mobility becomes more of a challenge, and people may have their own mobility aids. And we may even have people wearing calipers or adjusted footwear or be in wheelchairs for a long period of time. There is a huge amount of evidence about nature and being barefoot on grass and the power and the sensory stimulation that can give. And it's a bit to wonder about when was the last time you walked barefoot on grass to ground yourself? And this is some of the psychology around that. And then if a person had mobility challenges, when was the last opportunity they had to be barefoot on the grass? Subject for risk assessment, etc. And the other bit gathering much discussion is weighted blankets and weighted toys. Now, these have to be subject to risk assessment. Don't go out automatically and get one. We do know, for example, in some conditions, there is something called a thermoregulatory dysfunction. Essentially, the body finds it difficult to process when it gets too hot. My autism, I never know if I'm too hot or cold. I just know my temperature's not right. And that's part of my autism. Now, for some people with some genetic conditions, physically, biologically, the body cannot regulate temperature. And weighted blankets and weighted toys can rapidly increase the body temperature. So check that. Don't use it blindly. Just check. Could this cause a problem? Etc. And then, so those are some general things that people might want to think about, but always please remember the risk assessment. And I put as well as regulatory dysfunction, there may be some mobility issues. Can people push it away if they get too hot or it's too much, etc. And then what texture are you using? Can that set off respiratory problems, heart problems, etc. So risk assessment is quite important. And my advice to you would be to get an occupational therapist to carry that out. That's their area of expertise. So an OT support in doing a risk assessment for things like weighted blankets and toys would be my strongest recommendation. And then cognitive-specific interventions, things that can tap into our long-term memories. Giving brain space, time to regulate, and that includes some of these breaks for fatigue. Continuity and repetition. Objects of reference to person, time, or place. So an object of reference, and I've got an exercise later on, if subject to time, is something I've done a lot in dementia. And an object of reference is something that symbolizes a time, place, or person that I keep in a box. And when I ran a day hospital for people with dementia, these were adults, we did lots of work in developing objects of reference boxes. And in that box, we would have items that represented something about us, either from our past or from our currency. And it gave us a vehicle to talk through and talk about. And because it was a tangible object, it was able to attach itself to more things than just looking at a photograph. So more on that to come, but objects of reference is something that many of us can do straight after this session as something to proactively do straight away. Creating now moments of delight, which I'll be discussing next, and also understanding the person's processing level, which I'll come on to. So these three things are things that we can learn from adult dementia that potentially you can apply today to childhood dementia. So, finding your moments of delight. So we can argue there's two things, an anticipatory value and a currency value. Anticipatory value things are things that we strive to achieve that we think will make us happy. And often they do, sometimes actually they don't. So it can be a role, a career, or something more material like a car or a house or new clothes, etc. So one example, which is mine, my anticipatory value, the thing I find will give me great happiness is to be a professor. Now, I'm not. What am I? An associate professor, not quite a professor, but I'd love to be one. And I think if I was one, I'd be really, really happy. The question is, would I? I thought that when I became a doctor. To be a doctor, I'd be really, really happy. But then I became a doctor, and I thought, okay, I'm a doctor. And it felt almost anticlimax. So our anticipatory values we place on things may not always reach the expectation we think, but we are striving to achieve those. Currency values, I think, are a lot more important in dementia. Something that in our one moment of now, we find extreme comfort and pleasure. And that's not dependent on how we think it makes other people judge us. If I became a professor, would people take more interest and notice of what I say because I'm a prof? So that is dependent on other people viewing what I've got. Your currency value, your individual moments, now moments, are not based on anyone else, it's based on you. And one example is getting into a freshly made bed. So I don't know what your thoughts are, but say that the bed laundry has been done. As long as I remember to make the bed, not going to an unmade bed, that's a nightmare. But making the bed with freshly laundered bed things and then getting into that bed for the first time, that's a huge now moment of joy. Great. Getting home and eating, I think I've spelt that wrong, but a box of Maltesers with my feet up and the dog sitting on my lap, watching TV. That doesn't cost a lot. It's a huge moment of joy. Currency value. And I don't think I've got time to discuss it with the group because I've got so many interesting things. But essentially, what I was going to ask you about was, what's your currency value? What do you have that gives you that immediate notion of joy? And that's not dependent on others. That's just right for you. And for some people, it could be sitting in the corner of their lounge reading a book. Other people, it could be a freshly made bed. There are different things. And sometimes we can be surprised as to what it is. What is it that suddenly made you feel really happy for that one moment in time? So when we think about what those are, we can try to think, what are the opportunities to give currency value, those one moments of joy, to the children and adolescents that we're supporting? How can we influence their now moments? There may be a lot of discussion in childhood dementia about investigations, treatment, etc., and long term. But for now, talking to you people here, what can we do now straight away to give that one person that real moment of joy? And if it's changing the bed and putting some really fresh bed sheets on, great, that's a now moment. If it's that taste of chocolate in the mouth, if it's, and I often think this sometimes, If it's just sitting somewhere in the sun with the sun on my cheek, creating that glowing sense of warmth, huge now moment of joy, etc. If it's a dog sitting on my lap. So it's just taking that moment to recognize, and that's the important bit, recognize what are the now moments of joy for the child and how can we build that in as much as we can, because that's important to them. So now moments of joy, delight, whatever we call it, we do know that memory and emotion are strongly connected. So if it's giving us a really positive emotion, reaction, we may not remember what it was that happened, but we were likely to remember how it made us feel. That's an important thing to understand. Memories may be lost, particularly short-term memories, but what we're less likely to forget is how we felt. So now moments in producing that moment of delight and joy may help solidify relationships. How we feel is often linked to a person or a place. So we have an opportunity to develop those things. Creating, and important here, sharing now moments of delight. And often we get a greater experience when that moment is shared with another. It becomes reciprocal, and that can sit in our memory for a lot longer and create some emotional connectedness. So even if my wife, for example, if she developed dementia and she found a particular moment of joy in doing an activity like eating a certain chocolate bar, watching the TV, etc., I would join her on the sofa in doing that. I would share the moment with her because that would increase that emotional connectedness. So that may be something you may want to think about. And then we've got this general concepts in case there's anyone here from schools or education, thinking about what a child enjoys, what social practical skills do they want to develop, keep learning fun and meaningful, revisiting personalization. And I put revisiting because as the condition progresses, we may need to revisit what's now important to them. Learning with coherence and making links through relevance. Metacognition and multisensory processing. Little and often, don't overtax. Creating a list of preferred keywords or phrases to use. That's a really important one. What words or phrases are important to them? And my wife already knows my favorite word in the world is comfy. As soon as I hear that word, I feel relaxed, and it's just a lovely word, comfy. So she knows if ever, for example, I'm distressed or if I get dementia, etc., come here, I've come to make you comfy. That will mean something to me. And that's a word where I know I'm going to feel happy. Makaton. I don't know if I'm on the screen or not. You may just be able to see the slides. But Makaton is a form of sign language. It's not sign language. It's a system of communication. And my brother used it. And essentially, if he couldn't find the words, he could find the sign. And it's very much a bit like BSL, British Sign Language, but modified. So it becomes a lot easier and simplified to use. We use the word, we use a sign, and we can also have a symbol. So it's an interesting element to discuss how we use or support children with a progressive condition with Makaton. So when they lose the words, we've still given them a system of communication, and it could be a sign that they use. And I don't know if you can see me or not, but if I pick my hand up and I wiggle it, that means pain. So if I'm doing this, I'm saying I've got a headache, even if I can't find the words. So considering how Makaton could be useful is one thing. Repetition identifies with person, time or place, objects of reference. So if someone had the same, I'll give an example, again, going back to my adult dementia work. When I was supporting someone who progressed a lot in their dementia, and I wanted to let them know that their daughter was visiting, what I did with them is I got this scarf, and on that scarf, the daughter sprayed her favourite perfume. And then when the daughter was, and she had one, and we had one at the care home. And when the daughter was visiting, I would have this scarf and I would give it to the person so she could smell it. And although she couldn't use words, she would smell it. And that was me saying, this is an object of reference that symbolizes your daughter. Your daughter's coming today. And over time, through association, I would hand that to her, she'd smell it, and her eyes would, when we say, lighten up, and the mood would change, because that was me telling her, your daughter's visiting. And then a daughter would visit with a similar scarf, texture and smell, and we would create that link. Objects of reference. And we can use that for reminiscence. We can use it as opportunities for delight. We can use it also to communicate, etc. So I hope that's useful too. And space for resting. Now, one thing, and I'll be quick about this, this could be a session in its own right, particularly for professionals, but also for family members. If you choose to Google Jackie Poole and the pool activity level, I think it's fabulous. I've seen no work with it yet tested on childhood dementia, my next project, so hopefully I'll be in touch with that. But we use it a lot. When I ran a day hospital for adult dementia, I used it a lot. And essentially what it says, and it's used so much in adult dementia, what it says is as people's cognition progresses or deteriorates, declines, whatever word we're using, then we need to look at a different level of support to make our interactions meaningful. And it's divided into planned, exploratory, sensory, or reflex. So here we have the two. Planning level, the person is able to do these things. So complete activities, follow instructions, aware of others, but some support may be needed to one side in case I get stuck. As things in adult dementia deteriorate, and here I want you to think, could this apply to childhood dementia? As things deteriorate, they may then enter the exploratory level, where activities are familiar surroundings, memory aids are needed, but you may need to, they may become more creative. As things progress, we then enter the sensory level. There's a higher focus on sensations, singular activities, not too much at one go, and demonstrations of modelling may be needed. And then we move to the reflex level, where movement is responses to sensations, and we receive information through senses. So when I use this in a day hospital, for example, I was doing things like making a fruit salad. And on a planning level, we used to talk to the people and what should we get? And we used to go to the local shop together and purchase the items and come back and make the fruit salad. As people's level may have deteriorated within the group, or some people at the exploratory level, we'd change what we do. We would still do the fruit salad, but we do it slightly differently. Bear in mind, they're now cognitive working at the exploratory level, and so on, all the way down to sensory level and reflex level. That way, everybody was included, but we included them at the right cognitive level. So at the reflex level, I remember helping someone hold a strawberry in their hand and cupping their hand around it, and then feeling it mush. And they did laugh. Mush when it was squeezed in their hand, and then smelling the hand and the smell of strawberries, etc. They were still involved in making a fruit salad. It was just at their level, at their reflex level. So what PALS does is there is a checklist, and essentially you look at the different activities, washing, dressing, eating, and you tick a box that best defines how they carry out that activity. What they can do, not what they are doing. The difference is important. My brother, when my parents died, he had a learning disability, and when he went into care, I'm an LD nurse and I lecture, and I've written about LD quite widely. And it's quite interesting. I went to visit him in his care home one day, and I said, oh, I've come to take so-and-so out to McDonald's as planned. He loved McDonald's. Is he ready? He said, oh, I think so. I said, okay, shall I go get him, or do you want to get him? And they said, oh, he can get here himself. And I thought, he can't, he's in a wheelchair. At what point did that happen? And they said to me, call him. I thought, oh, all right then. His name was Sam. I went, Sam, come on, I've come to take you to McDonald's. And I was ready to do the Macadon signs and everything. And he walked around the corner. I was so embarrassed. I've been an LD nurse for decades. I've written on the subject. I never knew he could walk, but he lived at home all his life until my parents sadly died. And because they always put him in a wheelchair, they always thought he was in a wheelchair. This is the difference. What can he do to what he is doing? Now, I know it may be slightly different in childhood dementia. So what I'm trying to say is what can they do may be different from what they are doing. So we assess these activities based on what they can do. And then you tick the boxes and you may have more P's than E's, planning versus exploratory. But this checklist will then tell you this person is more likely to be at this level, and it would say to do these tasks, these are things you may want to think about. I think it's absolutely fabulous. There may be other things out there, but it's what I've used in the past. And it may be something you want to think about if you're trying to work, what can we do with my child at this person in time, or with this student, or with this client, depending on your role, because they're functioning at this level, and I'm not sure how we can adapt. The Jackie Poole work is brilliant. I have to say, it's designed around adult dementia, and hopefully I want to do some work in seeing how far we can relate this to childhood dementia. And it'd be interesting if anyone has used it in childhood dementia, because I think that can be a really important thing that we can support people with. A great intervention in your toolkit, whatever role you are, but particularly for parents and family members. And the objects of reference box, I mentioned it before, shoebox or similar, fill it with objects that symbolize experiences or cherished memories. And under the lid of the shoebox, I put an envelope. And in the envelope, I'll glue it in. And in the envelope, I write down what each object symbolizes. Because it can seem a very random object, but you know what that means to that child. We may not know. And there may come a time when we are supporting them using that box. A watch. For some people, it may mean time. Other people, it may symbolize who gave them that watch and the meaning it's attached. For other people, it's a watch they've seen on their favorite TV program. So always be aware to make a note of what that means. And sticking an envelope with these cards inside in the lid of the box is a good way of maintaining that narrative. And then what I used to do is I was to get that box and open it up and sit down with people and say, let's go for your box, shall we? And often that box would contain objects that were tactile or had a certain smell. So, for example, in Batten's, when vision becomes lost, we're not relying on a photograph. We can hold the object, we can smell the object, we can manipulate the object, and that hopefully can link into some memories. So if we had more time, and I know we haven't because I've just seen the time, but I could talk to you forever. This is hopefully giving you some prompts to think about. But is it worth considering starting an object of reference box if you haven't got one already? And then as conditions progress, you may want to refine what goes in that box, but you've still got this box of cherished memories that contain objects, not just photos, that you can use to talk through. And I think what I'm trying to say here is there are many things we can learn from the adult dementia world that possibly we could apply to childhood dementia. So what can we do now? The first thing is, if you're a parent, please know this: you are not alone. There are places like Niemann-Pick, Batten's, I forget the full title, but their organisation, many more others, and of course, things happening in Scotland and the Childhood Dementia Initiative in Australia. You are not alone. There are networks out there. If you are in the workforce, a clinician, an educationalist, I'm here to help support some teaching. My focus is on developing the workforce, etc. We need to ensure that our workforce understand childhood dementia, whether you're an OT, a speech language therapist, social worker, teachers, etc. We need to lobby to ensure childhood dementia is in every dementia policy, support initiatives for funding research, campaign and lobby as we need to, and be part of, or at least make other people aware, because we may not have the energy to be part of initiatives, but in essence, I think the first part is the most important bit. If you're a parent, you are not alone. That's the key takeaway from that. And there are things happening around the world, in Australia, in the UK, here, many more than that. That's just me putting the bits that I'm currently involved with, but there's many more than just that, including, of course, your very own Niemann-Pick UK Society. And this is the last slide. If you wanted a contact for some of those, you've got Rares and Tony for the NPUK. But also, if you want to know more about the Childhood Dementia Initiative, the fabulous work done there, there's a contact, an email address. Email address or website, I forget, always mix them up. There's me, if I can be of any help at all. And of course, there's the sterling work done by the Alzheimer's Scotland in Scotland. And I've got Jill Carson there as a contact, particularly if you're in Scotland and you are jumping onto this call. Do know there's some really important work happening there right now with, I think on the 11th of December, this report that Tony mentioned at the beginning, which is hopefully they'll be discussing with the Scottish Parliament on the 11th of December. So I'm going to stop sharing. Hopefully I'm now, as it were, back in the room, hopefully in time. There's so much more I could say, but I'm not going to say any more. I just want to say thank you for giving me the opportunity. And if there's anything left under-discussed you'd like more information on, then do let Tony know, and I'll happily come back and focus on an element. This was an introduction, but for now I'm going to be quiet and hand you back over to Tony. Tony, over to you, and thank you.
Thank you, Chris. That was fantastic. Very informative, very sensitively delivered, but also very thought-provoking, and we really do appreciate it. We did have some questions come in. Some of those have been addressed as you've talked through your presentation, but the one that I'd love to end on, if people will stay with us for just a couple of minutes, is what role do you think that families and patient organisations can play in shaping services and policy around childhood dementia?
Oh, thank you. I think if one of the biggest roles to play is to accept and support the term childhood dementia and make that part of our collective vocabulary. The more we use it, the more people will listen, the more people will not be, some people may be worried about using the term. The more we use it, it becomes an appropriate term to be used, not only by parents, but also by clinicians. Some people face a big battle in feeling comfortable enough to use that word. And once we're using it, it helps us then look for what matters to us individually. And for some people, it is too much joining organisations, etc., because your time is precious as it is. But being aware there's places you can go to dip into support is just as important as having this collective voice and supporting our advocacy work going forward.
Thank you, Chris. I couldn't agree more. And I think it's great that we will have the opportunity to amplify that voice and the use of the term through the launch at the Scottish Parliament, which is taking place on the 11th of December. And we will look forward to sharing that when it happens. Thank you to everyone who has joined us today. My thanks also to Raresh Danshu, our social media assistant, for helping to manage the webinar, and of course our expert speaker, Dr. Knifton. Thank you so much, and hopefully we will see you again for a second webinar in the near future. Thanks a lot, everyone. Goodbye.